If it's okay, we're going to go ahead and get started. Again, welcome. If you're wondering where you are at the International Competency-Based Health Professions Education Collaborators webinar series. Depending on where you are, good morning, good afternoon, or good evening. Sound like Truman Burbank from The Truman Show. This is the first webinar of our spring webinar series. It's our first webinar of 2026. We're very excited to have this with you. If you're not familiar with the Collaborators Group, it's a group of educators from across multiple different health professions from all over the world working together to explore, critique, and advance competency-based education. My name is Ben. I am a MedPeds doc in Cincinnati, Ohio, and I'm a member of the Collaborators Group. I'll be hosting today's webinar, and we're going to be talking about narrative and story in competency-based education. We'll get a little bit more into that before I introduce our two featured speakers. One thing to note, there is a YouTube channel now, thanks to our communications team and to Christina, who's on the call with us, for putting this all together. If you want to see previous webinars where we've covered everything from implementation to research to technology to assessment, you can go to this YouTube page at ICBHPE Webinars and find recordings of those old videos. And the recording of this one will also be put up there after with this session. So the title of this was about story, and I just want to start by referencing this book. I don't know how many of you have seen this book. It's one of my favorite books. I reference it all the time by Dr. Lingard and Dr. Watling. You can see it's titled Story, Not Study. And it's a book on academic writing, specifically in the health professions education. And they foreground the importance of using elements of story in academic writing. It's one of the most important messages of the whole book. Now, I want to be clear, I don't get any proceeds from the book. I'm not in the pocket of Dr. Lingard or Dr. Watling, but I really do use this book all the time to both ground my thinking and especially ground my writing and to always bring myself back to story. I've shared this book with a lot of different people, a lot of people I mentor or friends or people who are trying to improve their writing. And so many people I share this with are just surprised by the emphasis on story, as if story is taboo or in opposition to academic thinking and writing. But I want to, before we get into stories today, I want to foreground the fact that stories really matter. Stories have been around forever. Ever since there's been communication, there's been story. And it's been part of science. It's predated formal science. It's really a part of how we think. It's part of our cognition. It's not the opposite of rigor. It's part and parcel to rigor and cognition. And I like to think about story building as theory building. Theory plays such a big role in what we do in health professions education and in competency-based education. And that really is kind of a form of story building. When I think of theory, I always try to, when I meet with my learners and I talk about theory, I think about theory as connecting the dots between bits of information. So if you think about information as data that we collect, trying to understand how the world works, theory is when we draw connections between those pieces of data, whether it's causal inferences, whether it's just associations, or just trying to figure out how things relate to one another. That's theory building, and that's story building. That is building a story. And it's more than just theory building. At every level of inference or understanding that we take, it's a form of story building. Some of you may have seen this, this pyramid before, where you go from data to information, information to knowledge, knowledge to wisdom. Each one of those leaps takes an additional ingredient, whether it's adding context or meaning or insight. Each one of those things is an element of story. And oftentimes story is kind of the fulcrum around which our gain and understanding happens. I also want to point out that we literally access the world through story. You cannot experience the world without story and narrative in your life. There is a view of how we interact with the world called naive realism. And I think some people, or maybe many people, operate under this kind of assumption without even really thinking about it. The idea that we encounter the world, we see things, we hear things, we experience things, we feel things. And based on that experience, those sounds, words, thoughts, sights, they evoke a feeling and we react to it. So we are directly interacting with the world, and those interactions drive our behavior. But I think more and more people understand that there's nuance to this, and there's an extra step missing, where we create a narrative and a story around what we're experiencing. So we're not directly reacting to what we see and hear. We see and hear things, we encounter experiences and moments, and then we develop narratives to interpret those things, whether it's something somebody told us, whether it's something we see out in the world. We are all creating narratives to understand things, and that is what provokes our feelings and our actions. This is called critical realism. And if you've ever taken a dive into Stoicism or literature on feedback, or on internal locus of control, this moment, this space of creating a narrative around what we're experiencing is totally pivotal to it. So again, we are not only using story to understand the world, we are literally experiencing the world through story. It is part of how we make sense of the world, how we integrate facts, values, emotions, context, how we understand complexity and uncertainty, which is really important in the space of health professions. Really, story is everything that we do. So we thought it was important to try to bring story to this series and really lean into story over the spring and sharing stories around competency-based education. So I keep using this word story. What do I mean by that? Well, I'm not an expert. I'm not a expert storyteller. However, when you dive into the literature on story, there are many, many different definitions of what a story is and what it can look like. But here are some common elements that I saw across multiple places. Most stories have an element of time to them. Doesn't mean everything has to be totally linear or moving forward in time. Some stories jump around in time or go backwards through time, but there's usually some sort of time component to them. There's often some element of causality. One thing causes another, and this is usually how tension is built or how a plot moves along. Oftentimes there's meaning, whether it's a moral to the story or whether it's just some sort of meaning can be derived by the reader, even if it wasn't intended by the storyteller or the story writer. There's obviously events. Things happen, right? There's usually a plot of some kind. I think most people have seen this idea of rising action, falling action, where there's some sort of tension or inciting event, climax, and resolution. This is very oversimplified. This is not what all stories look like, but the idea that there are events and sometimes there is an ebb and a flow that is frequently used across different types of stories. And then lastly, there are characters, all types of characters, not just people or animals in the case of Winnie the Pooh, but sometimes objects and concepts can be characters. Time can be a character. Locations can be a character. All sorts of inanimate objects can be characters, but characters play a role in stories. So most stories have some of these elements, if not all of them, that are enacted in different ways. And that's why stories can look so many different ways whenever we encounter them. I want to point out that what we do a lot in terms of didactics around competency-based education sometimes has elements of story, but we so often kind of foreground other things rather than leaning into story. And so with this series this spring, we are really going to lean into the element of story as we try to share knowledge, build wisdom, and frankly, just share experiences. There's a lot of potential benefits and impacts of stories. I listed some of them here, both from helping us remember to helping us understand, to derive causal reasoning or organize our experiences, all these different things. Story is part of all of it. And I also want to just point out that story is not just for organizing data. Story also generates data, and it is an actual research tool. I want to specifically call out this paper by two brilliant researchers, Dr. Anderson and Dr. Bullock. And this just came out this year. It's a brilliant, brilliant paper if you're interested at all. They use something called story cycle methodology to weave personal and literature-based narratives to illuminate, interrogate, and challenge the premise of what they called extraction in health professions education. Really brilliant use of story. Again, not just to bring context to something, but to actually generate data. Really well done. So story can be used for so many different things. And for those of you doing competency-based education initiatives, story is a great way to enact change. We've done previous webinars on change management, and the idea of story has popped up. But in terms of trying to influence, persuade, gain understanding, story plays a big role. For those of you who have any background in rhetoric or argumentation, you might recognize some of these things: ethos, pathos, logos. Going back to Aristotle, these were the different aspects or facets of argumentation. One of the most influential ones when you're trying to enact change is pathos, this idea of bringing in emotion and motivation, the human side of things. We are not thinking beings that feel, we are feeling beings that think. And so story is one of the best ways to access pathos when you're trying to enact change. So throughout this spring, we're going to call on people to share their CBHPE related stories, different types of stories, transformation stories, challenges, identity or culture related stories, stories related to context, or frankly, just stories that are interesting and fun. That's what we're going to be doing. And so because we recognize this is a bit of a departure from what we normally do, and because sharing stories can be kind of vulnerable, we have two brave volunteers who elected to go first in this first story-based webinar series. And I want to introduce them now, and then I'm going to turn the mic over to them. After each story, I may ask a few questions, but if you have questions, please put them in the chat, and I'm sure that our speakers will be happy to answer them. So our two speakers today, they are people who've been doing a lot of great competency-based education work for many years and have been leaders in the field. I'm going to introduce both of them now, and then I'll start with Dr. Atkinson. So Dr. Adele Atkinson is a professor of pediatrics, the Department of Pediatrics at University of Toronto. She's also a consultant immunologist and allergist in the Division of Immunology and Allergy at the Hospital for Sick Children. She's Associate Chair of Education as well as Chair of the Specialty Committee for Pediatrics for the Royal College of Physicians and Surgeons of Canada. She's going to lead us off. After Dr. Atkinson, we'll have Dr. Kelly Kavarzegi, who's a Professor of Internal Medicine and Senior Associate Dean for Education at Oregon Health Sciences University in Portland, Oregon. He's also Chair of the Council of Medical Education for the American Medical Association and has been leading competency-based education initiatives for many years. So I'm so grateful to both of these folks for being brave, sharing their stories with us. When I asked them to share stories, I said, you can share any kind of story you want, and then we'll build knowledge and reflect with it. And for those of you who are watching, I want you to think about questions you might want to ask, put them in the chat. And if you yourself have great stories in the world of competency-based education that you want to share, reach out to us after this because we'd love to provide a venue for you to share your stories. And so with that, I will turn it over to Dr. Atkinson, who is going to share her story with us.
Thanks so much, Ben. Good morning, everybody. So I'm going to tell you a story, and it's not a bedtime story. It's not supposed to put you to sleep. In fact, it's supposed to keep you awake. And maybe you could think of it a little bit like a documentary, or for those of you that are familiar with the Serial podcast, I'm going to channel my inner Sarah Koenig, if you know who she is. If you don't worry. You will know a little bit more after I tell the story. So the title of my story is Competence as the North Star. Have we drifted away because it isn't comfortable? So this happened to me. About a year ago, I was on service at the hospital where I work as a pediatric immunologist. I was covering the inpatient consults, which are always mind-blowingly complex at our tertiary care referral center, and I was handed over a very complex patient who was very unwell in the intensive care unit with a story that made me sit up and listen and pay very close attention during handover because it was almost unbelievable. This lovely 16-year-old man had been, and he was young, he was 16, he's still a young man, had been previously completely well, living his best teenage life, and then suddenly, as we like to say in medicine, crashed overnight with an infection so severe he had to be put on ECMO. For those of you not familiar with ECMO, it's essentially a machine that does the work of the heart and the lungs. And he was found to have an overwhelming viral infection. I mean, a virus that's supposed to cause a mild illness. And this young man had a viral load higher than any of my infectious diseases colleagues had ever seen. And that's saying a lot, given where they work. So, for sure, whatever his diagnosis was going to turn out to be, it was going to be in my clinical backyard. On Wednesday afternoon of that first week on service, I went down to the ICU to see the patient and to chat with his mother, who I had met a couple of days ago. Understandably, she was overwhelmed. There was so much coming at her, so much stress. As a mother, I couldn't even imagine. The learners were at their half day of teaching, and I was covering the pager. I find that's always a nice time to go and chat with the families when it isn't rushed and I'm alone and I can just get to know them. When I arrived in the ICU, I asked the unit clerk, who I've known since I was a fellow and who has now seen me 3 days in a row, if he could find the staff who was looking after the patient so we could touch base. After he asked me if I was lost, because immunologists don't find themselves in the ICU very much, we had a bit of a laugh, and then he went off to find the staff who was on service. So the staff turns out to be a great colleague of mine. We were fellows at the same time when I did my training in bone marrow transplant medicine. I made patients sick with all kinds of nasty drugs. He took them to the ICU, stabilized them, sent them back to me. Outstanding clinician, always leaned into the problems and the hard things. One Saturday, when I was the transplant fellow on call, one of my patients lost their central line. That's an access port through which we give medication, and we actually do the transplant through that line. And I needed to give chemo. And the interventional radiologists told me they don't work on the weekend. So I called him, and without a second thought, he told me to bring the patient to the ICU, and he put a new central line in for me. That was just who he was. So he comes to meet me and we chat for a little bit about the patient. It's been over 20 years since he put that central line in for me. Then he asks me if he can change the subject. Sure, I said. He looked troubled, maybe a little vulnerable, especially for someone who every day works in such a high intensity specialty, and to me was always so confident. As residents, we used to call the ICU fellows cowboys, and I guess cowgirls, although it was more cowboys in those days. And he was kind of one of these, but in a really good way. We laugh about the cowboy thing. He brings up a challenging time he and a few others had had a few years ago when a couple of learners rotating in the ICU gave him and some other ICU docs poor reviews. Intimidating, they said. Demanding. They felt singled out. They described the learning environment as toxic. It wasn't the first time. It wasn't just him. And in my role as vice chair education, I was the one who had to address it. Again, and with his division head and him and others. It wasn't easy, but we had the conversation again. And given that removing learners from a faculty in the ICU wasn't an option, because there's always learners in the ICU, some of them were temporarily removed from clinical service. This is a devastating thing for those who value clinical work and are good at it. I remember at the time he was angry. He got a little sarcastic with everyone, put his head down, continued his research, another thing he's very good at. He didn't agree with the feedback. Eventually, normal clinical service resumed. It was behind him and some of the others. It's been quiet, but to me, he hasn't been himself. So on this day, he told me that he knows that this has had a significant effect on his career, and he gets it. He knows he could have, should have behaved differently, but he says and goes on to tell me how worried he is about the competence of the ICU learners he meets. He tells me that the acuity of the patients they care for is going up and up. He tells me that they're keeping children alive, a good thing that they couldn't have kept alive 10 years ago. Good pre-hospital care, top-shelf transport teams that fly all over the place with tiny little portable ECMO machines, critical care docs who are in the field prior to transfer, all of it. We went back to talking about the patient. He told me that getting this patient onto ECMO had been challenging, specifically putting in the special lines. Remember, something he's very good at. It was touch and go. But here we are, and this 16-year-old boy is alive and improving. He went back to his reflections. He told me that all he has ever wanted to do was ensure that the learners were competent to do the job they have to do, which is a hard job, where kids die every day. He told me that he worries that because he feels he can't give authentic feedback, get them to struggle a little, that they won't learn. And he doesn't fully understand, he admits, their feelings of lack of safety and feels that maybe it's generational. Yes, he said that out loud. I mean, one could argue that there are a whole bunch of his colleagues with pretty good evaluations, but there's also a whole bunch of his colleagues who get similar feedback. I told him I heard what he was saying. We talked about finding a way to do both, which he knows he has yet to find. And he doesn't know how to get there. Maybe he worries that getting there will change his feedback, dilute it. I don't know. And to be honest, I'm not sure he really agrees. He worries that they need to feel uncomfortable or they won't be able to do the job that is needed. Just then, one of the nurse practitioners that we've both known for a long time came up to chat with us, so we had to stop this part of the conversation. The last thing he said to me was this. He looked through the window at the patient who was now off ECMO, but still ventilated, responding to therapy and going to survive, mother sitting at the bedside, and said, "What if someone can't get the central line access needed in the middle of the night when nobody's around? That is why we need to make them uncomfortable so that kids like this survive." He walked off to chat with our nursing colleague. I went in, I spent some time with the patient's mother. Lovely conversation. She was cautiously being a little happier as she saw improvements. She showed me videos of her son on TikTok working out and asked to see photos of my kids. I went back to my office and I couldn't get this conversation out of my head. People are not one specific thing. While some of my colleagues' behaviors in the past were not okay, I find myself sometimes with the same worries about the development of competence. At least 3 to 4 times a month in my current role, I have to manage similar feedback about one of our 220 faculty. I have an approach. I look at their feedback. I triangulate the data the best that I can. I speak to their direct supervisor, try to get a sense of whether this is a pattern. It usually isn't. I speak to the faculty to get their perspective. There are multiple sides and perspectives on these situations. I sat at my desk reflecting on the conversation and very quickly got a text from my colleague in the ICU, thanking me for chatting, asking if we could do it again sometime. Of course, I said. I sat and thought about what was bothering me. It was a few things. It was the multiple stories from my colleagues telling me that they did not feel they could provide authentic feedback and coaching to learners due to perceived retribution through the evaluation system. It was their comments like, "I have to walk on eggshells," and the look on their faces of resignation as to how they perceived things to be. It was my worry about how do we coach to competence and adaptive expertise if the exact people who can do it aren't doing it for one reason or another. It was in part my frustration, as I truly believe the design of competency-based education not only should teach to competence and adaptive expertise, but do it better than we've done it in the past, with intention and precision, yet there's all of these conversations. This is one of the wicked problems in medical education that I sometimes find myself obsessing over. I mean, I don't lose sleep, well, maybe a little, but there are just things that I can't get my head around how to tackle because sometimes it seems so clear to me, and maybe I need to see it through the lenses of others, like my ICU friend and his colleagues. It is the notion of productive struggle, pushing learners to the zone of discomfort, and how essential it is to the development of adaptive expertise and competence that I worry about. To be clear, that itself is not the problem. That is not up for debate. It's foundational fact. The problem is how to ensure it's actually happening when there's a groundswell of antibodies towards things that feel uncomfortable and unsafe. I sometimes feel like the discourse around this is endless. I have found some ways to manage the worry. We decided our medical education day in our department would be inviting education scientists to speak to our faculty of the how of the notion of productive struggle and adaptive expertise. Really practical, less theory. We've had journal clubs on the papers. We're trying hard to change the conversation on the ground. We speak to the learners who come to train in our department from around the world, 400 at any given time from 30 countries, that this is the way we teach. They will feel uncomfortable at times, and we encourage them to lean into it, and they will be supported. We collaborate on papers about it. Human interactions are complex and nuanced. We know what this all looks like in a perfect CBME world that we will never live in. With the perfectly imperfect world we are left with, we need to keep competence as our North Star, the care for our patients and their families at the center of everything we do. We need to listen to our colleagues and our learners, learn from them, lean into their discomfort, keep the conversations going, and not get lost in our efforts to make everything perfect.
Wow. That was a powerful story, Adele. Um, I really, really appreciate you sharing that
Thank you.
and for putting so much thought to it. Two things. One, I want to invite people, if you have questions or reflections, to share them in the chat. But Adele, I wondered before we get to Kelly's talk, could I share some reflections or questions with you?
Absolutely. I hope I can answer them.
Well, one of the things that really strikes me and where I think story works so well here is this is a very human story. It kind of highlights the challenges of education in general. That competency-based education as a philosophy of training is like super aspirational. It's like this amazing aspirational idea where we at the same time hold high standards of training and competence with psychological safety, with feedback and assessment that are often used for different purposes, and support, and then the messiness of having a wide range of both educators and learners and where their edges of competence and comfort are. Um, I think that I've heard a version of this story many times over both in a competency-based education world and beyond. But I think competency-based education, because it is calling people to really have high standards, to be thoughtful about assessment and feedback, and because accountability to society is at the heart of the why, it really like shines a magnifying glass on these tensions. And I'm just curious, after thinking through this story and reflecting on it, is it going to change how you approach critical feedback with learners at all when you're in the clinical working environment?
Do you mean personally? Like,
Yeah.
so I wonder what I sometimes think about is when I work with learners, the decisions, sure, we make tough, hard decisions and we have to make decisions with gravitas, but there's always time. And I wondered how much of this with this colleague of mine and his colleagues within the intensive care unit and other acute care areas where I've seen this, I wonder if I think about it a little bit differently because they're making decisions and doing things that there's no time to think in the moment about, am I being nice enough? And I wonder if a piece of that is the acuity and the stress that everyone is under in these environments. It's maybe a little different from mine as a consulting service where we come and we advise people. And yes, we have sick patients, but we're always the ones thinking about their T cells and B cells. And we're not putting in the cannula in a moment where there's 30 seconds before this patient's not going to make it if we don't get them onto ECMO. And so part of what I wonder is it's not the same across the disciplines, I think. And I was talking to one of my colleagues about this the other day. She said the following thing to me. She said, faculty are very worried about the feedback they get on their learning environment. And I think David's on this call. He may actually know what I'm talking about. So faculty worry a lot about the feedback on their evaluations from learners because, especially when they go for promotion. And one of my colleagues said to me, why can't they just lean into it and kind of go, yeah, I need to really think about that. And I said, because it's summative, kind of like the learners. So we tell them it's all formative, and then they go to a competence committee and they get judged and adjudicated. And they say, yeah, it can't be both at the same time. And lots of good, smart people like Chris Watling and others talk about how you need to build a system where both of these can be supported. But I do wonder if it's different. And I try to lean into the feedback that I get from the learners, but my relationship with them and how I work with them is different than in these really, really high intensity acute care environments. And I wonder if some of our surgical colleagues find the same thing. You don't have 2 seconds to tell someone to get their hand off that vessel or get the knife out of the way. You can't say, listen, I need to tell you something. We're about, it's sort of a different thing. And some learners, we also know that learners are very different in how they incorporate and internalize feedback and what they sort of feel they can manage, I think. And so some of that, it's very messy. And I don't know that it won't always be messy. People talk about being in the messy middle and then we'll come out of it. Maybe we won't. Maybe we'll always be in the messy middle and we have to learn how to function within that. I don't know if that answers the question, but these are the things that sit in my mind all the time.
Amazing reflections. I totally agree with you. And I just want to reflect back. Dr. Schiffer Ginsburg wrote a really great paper on some of the tensions with teaching evaluations, evaluations of teachers that highlight some of the things you said. And I also want to call attention to a comment Dr. Chan made in the chat about relationship. Curious about the reality of professional relationships between learners and faculty, how little we attend to relatedness. I think that's such a great point. And she wrote, if no or little relationship, how can we facilitate trust in general or about the feedback provided? And such a brilliant point. I don't know if you have any reflections on that at all.
Yeah. So Minka, this is an excellent point. And I want to tell one quick little story. When I was program director for Core Peds a number of years ago, the residents came to me that were about to be the trauma co-team leaders. And they said, we're terrified of the CCRT doctors, the critical care response team doctors, because those are very experienced 3rd, 4th, 10th year PICU fellows who come to the room when there's a code called, and then there's this random PGY3 at the head of the bed calling the shots. And they said, we look at the door, we see this person, and we totally freeze and freak out. And I said, okay, this I kind of get. Like, I get that. And, and the CCRT on the other side were like, we're there just to make sure it goes well and to be a resource and all of the things. And they truly are. They don't want to take over. It's not their first rodeo. They want to be there to support. They're very extraordinarily competent at this particular task. So what we decided to do was we decided to have a social event. We decided when these residents, before they turned to be PGY3s, when we were having our orientation, we would have a social event with the critical care fellows, the response team fellows. So we had this kind of like social event where they were all together, getting to know each other, and we had coffee and like we had some fun, icebreakers and whatever. And they started to know each other, call each other by name. And then we sort of did a little bit of a check-in a few months into the academic year when now those PGY3s are running the codes and those CCRT fellows are coming and standing at the door and saying, I'm here if you need me. And it was transformative. That little thing we did to build a relationship, and they saw the person at the door and the person's like, I've got you, was completely transformative. We could have not done that. We could have just let them start and they could have let these other new fellows start and they'd meet each other for the first time in the middle of this chaotic situation. But that little intervention, which did not take time and only cost for us to pay for some coffee and cookies, actually made a huge difference. So I agree with you, Mika. I think the relatedness piece is really important.
I think what this tells us is that regular karaoke would really help with implementation of competency-based education, because there's no better way to build relationship than to karaoke together. I only say that because I love to karaoke, and I would love to see karaoke implemented into our. Could it be a core component of competency-based education? I don't know. I'll have to talk to Dr. Van Mill. I do think this also speaks to the lack of longitudinality within our education systems. I know Dr. Eric Warm recently wrote a great piece in the New England Journal of Medicine about challenges to longitudinal care, both within care spaces but education teams, with how medicine and medical education has changed. I should say health professions and health professions education has changed over time. And I think that contributes to some of this. Some other really great comments coming into the chat. If I could just quickly read them in case people who watch this video can't see them, and then we'll transition over to Dr. Kavarzegi. David Rojas writes, one of the main challenges is not the feedback to teachers, but is how the feedback is used. We have challenges around our feedback culture as we encourage formative feedback and then use it for summative purposes, like promotions. This is a system issue, and part of the potential action plan is to reimagine how teacher evaluations are used in the promotion cycle to lower the weight of the resident perceptions by contextualizing with other metrics of teaching excellence. Any reflections on that, Dr. Atkinson?
100%, David. So I knew that David would say something really smart in the chat because he thinks about this all the time. David, I totally agree with you. And I worry. So there's something else that's happening in Canada that's really interesting some of the time. Sometimes when residents are applying to the subspecialty match, the programs in the subspecialties ask for all of their evaluations from when they were a resident. Their IDERs, for those of you that know IDERs in training resident evaluation forms, their EPA comments and stuff, which makes absolutely no sense, right? So those are supposed to be formative, developmental pieces of feedback that help a learner grow. And if you show them to a subspecialty, there's no context. It also undermines the complete premise of everything we're trying to do in competency-based education, which is like not the least of our worries. So I agree with you. And the promotions piece is the same thing. We have to somehow use the feedback the way it's intended for development and growth. We have to be intentional about it, clear about it, and then stick true to it. And then find ways to give the people in the subspecialties and the promotions committee what they need to understand about a teacher in this moment that doesn't require all of this lack of contextual feedback to be provided to them where they read random sentences that have no context. So I totally agree with that.
Yeah, brilliant. I love these reflections. I would just love to mention one last reflection, then I'll open the door for Dr. Kavarzegi. This story was so, like, I could feel it in my chest as you were telling it, Adele. And that's one of the things I love about stories. Like it did evoke pathos for me. And I think that another thing this story highlights for me is the idea of an empathy gap, about how, as our positionality changes through our careers, how we perceive a moment and how the story we tell about that moment. As I mentioned, we tell stories about what we encounter, but also who we empathize with and the risks or emotions that we might draw from hearing a story change. And despite my youthful appearance, I'm getting on in age, and I certainly have a different amount of empathy gap from medical students and trainees than I did when I was fresh out of training. And I think it's interesting if the same story landed on the ears of people who are currently medical students or residents or fellows versus somebody who's well into their career. I think there is probably an empathy gap about what are the most important parts of the story, what are the risks, and what are the biggest challenges. Super fascinating to think about that as we think about stories, and we think about the story you told in particular, how where we are in our training and in our careers probably influences our reactions to it. So
yeah, thanks, Ben, and thanks everybody for listening.
I love it. All right. Our second storyteller today, our second brave volunteer, Dr. Kelly Kavarzegi, is going to share a story about competency-based education. Different story, maybe different storytelling approach. I don't know. I haven't heard these stories, so I'm getting to listen like all of you. But I'm going to turn it over to Kelly, and I'm going to share the screen whenever he tells me to. So it's going to be all Kelly for now.
Thanks, Ben. And congrats to Adele for such a wonderful reflection. I will definitely tell a different story than Adele, but I promised to this group that we did not collaborate and come up with our stories ourselves. But hopefully you'll be able to see some links between them. So I'm going to tell a bit of a story about a critical moment in my journey related to CBE and how we and me have evolved a bit and changed a bit over time as it relates to how I think about this, how I approach about it, and how I teach about it. So it's April of 2012. We're in Atlanta, Georgia, and it's the early afternoon. We are in day two of the spring conference of APTIM, which many may not know is the Association of Program Directors in Internal Medicine. It's effectively the post-grad program director group for internal medicine in the United States. I'm still in my 30s, I'd like to say my early 30s, but relatively young. An assistant professor. I'm an lowly associate program director at Henry Ford Hospital in Detroit, Michigan, which is a very large community-based residency program with about 40 residents per class at that time. Um, we're here about an hour before the address of the keynote plenary speaker at the conference. And you might have guessed it, that keynote plenary speaker is me. It's now think back several months prior to that. I was asked to provide some background and information about a fairly dramatic change that was happening in residency education in the US. It was the transition to the ACGME milestones through its next accreditation system, is what it was called at the time. What it did is it signaled the first attempt to focus our efforts on the outcomes of residents, as opposed to whether or not a program director simply followed the accreditation rules and the accreditation processes. In short, it was the first step to implement competency-based education on a large scale. I was fortunate enough to have been in on the ground floor of the Milestones movement in postgraduate training in the US, helping out with the internal medicine's efforts to write their milestones when I was a fellow at the University of Pennsylvania. We were one of the first specialties to go forward. It's funny, we actually ended up having two versions of milestones because as the first version we created wasn't quite aligning with what other specialties were doing, and inappropriately so, we wanted a standardized approach. So I was fortunate enough to ask to lead the efforts at the second or the rewrite of our original milestones, which brings me back to Atlanta. So if anyone on this webinar was there, and I looked, I don't know if there's anyone that was probably there. I know some in our groups, some in our larger group were. If anyone was there, they might be able to vouch for the tension of the moment. I mean, the entire process for program accreditation was changing, and not everyone was happy about it, to say the least. The room was packed full, standing room only, as I recall. I'd like to say that there were thousands of people there, but in reality, it was more, probably a couple of hundred, but they were an intense couple of hundred people. The name of my talk was Linking Milestones to Core Competencies to Help Programs Navigate the Next Accreditation System. What isn't apparent by the title is that I also was asked to link this to EPAs, which at the time was an emerging concept, as Ola and Fede's paper had been released in 2007, but really didn't take hold until several years after. And I'm sure you all know how easy it is to teach about EPAs, especially a brand new concept, and link it to something that is very high stakes. The bottom line, however, is that it was a big talk for a very interested audience, and I'm feeling pretty good with the necessary bit of excitement mixed with anxiety. And then it happened. I get a tap on the shoulder, turn around, and a friendly but worried face wants to know, do you have a minute? The tap came from the chair of the board. So of course I have a minute. We walked down the hall and into what was kind of a production room, and waiting there was the CEO. Now at the time, and today, I consider both of these folks to be friends and colleagues. They're truly great people, so it really wasn't intimidating, but it was intense. After asking me if I needed anything to drink and inviting me to sit down, the chair of the board asks, "How do you feel about the plenary?" I say, "Good, good," because I did feel pretty good and confident. They say, "Because you realize how important this talk is, right?" And now I'm starting to wonder, am I okay? Should I be nervous or should I be concerned? Well, in my relative youth at the time, and likely in exuberant overconfidence, I let them know, yeah, I do know the stakes, and yeah, I'm ready. Again, I said, good, good. They offered support and general vote of confidence, and we parted ways. So now I'm on stage. I don't have any idea what happened in the interim. I'm pretty sure I didn't go to the bathroom and vomit, but I'm pretty sure I did okay. But I'm on stage, and interestingly, a calmness settles in, along with a quiet confidence. I don't think it was cockiness, but it was a sense of just being prepared and ready to talk to an audience who wanted to learn, wanted to lean in, and wanted to improve the meaning of their work as program directors. Actually, the talk went really, really well, and to this day, I've not had a more satisfying professional experience. Most in the audience were supportive and appreciative. And I say most because not everyone was still happy with the idea. During the question and answer period, I distinctly recall a current at the time, longtime program director from New York City and a former leader of the organization as the elected leader. He came to the mic and asked with a stern and pointed tone in his voice, "What evidence do you have that these outcomes-based things will make doctors better?" My response was probably fueled by my silent and hidden euphoria, saying, "I don't, other than I have plenty of evidence to suggest that our old way of doing things isn't necessarily working either." It may have escalated a bit of tension, but also set the stage for what I believe to be our collective work. My point in telling this story is not about the nature of the big talk, but to illustrate the point that this CBME thing is a journey. It's been a conversation for me for almost 20 years, and it'll go on for 20 plus more. We are getting better at explaining it. We are establishing an evidence base. We have expanded our efforts to partner with multiple professions and now have international webinars, blogs, meetings, and societies all focused on competency-based education. So we need to keep it going. Now, the second part of the story relates less to the importance and value of the talk, but about the importance and value of conversation and the narrative of the story, or of the story, if you will. So Ben's sharing a slide. This is one of the slides from the talk that I gave in Atlanta. Likely the slide that most will remember from that talk for those that were there. And it was effectively the punchline, the part that I was most confident about. This slide, along with those leading up to it, ended up playing a big part in me establishing a career in medical education. I've likely used it well over 1,000 times over the course of years. To briefly illustrate it, and this ties back to what Adele was talking about, where we talk about competence, specifically the need for the residents to demonstrate competence. That's what we seek as teachers, leaders, program directors, and trainees. What this slide demonstrates is the reality that it's likely not possible for us to see all aspects of competence, to collect enough data, if you will, to fully see the entire word of competence. So how do we know? How do we fill in the gaps when we don't have data? How do we see competence? I believe we do that through conversation, through stories, the conversations that we have as faculty and leaders, especially inside of our clinical competency committees. So the next slide is called Then a Miracle Occurs. I used this cartoon in the Atlanta talk as well, but honestly, I used it for a different reason. Before CBME, I used it to illustrate how we made decisions about learners and their progression, kind of in a negative sense or pejorative sense, if you will. Now I use it to celebrate the non-discrete data pieces that truly inform how we think about our learners, which again is the conversation. The stories we tell each other about our learners, their strengths and their talents, their weaknesses and opportunities, their quirks and their intangibles, if we're honest. So Ben, in his introduction, showed a slide that involved a pyramid, starting with data and information, but ending up with wisdom at the top. I think that in CBME, it is the narratives and the stories about our learners where we actually learn about and take knowledge into wisdom. So I'm going to show one last slide. And this is really not about the story per se, but it is part of my story. I said I wasn't going to do this. This is a very good friend and mentor of mine, Bill Yobst. Bill is now retired. He's in his has been retired for several years. He's perfectly fine and healthy. Nothing's happened to him. But he really influenced me. Well over for a decade. He very much contributed to the CBE conversation. He was very instrumental at helping to develop, quite honestly, the collaborative that we all belong to. Um, this picture actually shows, um, I'm sorry, this picture shows how that Windows to Competence slide began in its infancy. Many years ago, and this was a year or two before that talk in Atlanta, he and I were at a retreat outside of Seattle. I'm sorry, folks. When I approached when I do this all the time, when I approached him with what I thought was a stupid idea that led to the most important talk that I ever gave. So just much appreciation to Bill. I do this when talk about things that are meaningful to me. I told myself I was not going to do this and prepared myself for it, but yet still got emotional. So that's really was my multiple stories kind of tied into one. What I hope that people get out of that is to recognize is that we're still on a journey, we're still walking, we're still talking. We need to continue to improve. We need to continue to think about think about how we change our um, how we think about the data that we receive and be sure to include the narratives in the conversations.
Kelly, that was amazing and super powerful. And you do not need to apologize for crying. I cry all the time. And I appreciate you bringing your full self to that story. I think all of us would love no better career legacy than to make as big of an impact on somebody as Dr. Yopes made on you. So thanks for modeling that.
Thanks,
I wondered if I could follow up with a couple of questions for you, like I did with Dr. Atkinson. And again, I want to invite people to put any questions or comments in the chat as well. Kelly, one of the things that sticks out to me is this moment where you gave this big talk in a room full of internists, which I have to be honest, as an internist, I've never been described as intense. Usually we're the least intense people at any given conference. You can always tell us because we're wearing a lot of browns and scuffed shoes versus the more high-powered specialists who have nice shoes and nice jackets. But I know that feeling. And in that moment, your identity changed within your community. You became the competency-based education person.
Mm-hmm.
And as people are doing this work, people who are on this call who might be doing competency-based education, leading competency-based initiatives, something changes in us as our professional identities change and we take on that role. And as you navigate competency-based education initiatives and even encounter challenges or critiques, which I think are a healthy part of the dialogue around competency-based education, how do you navigate holding that identity of being the CBE person or one of the CBE people, and then you face critiques? How do you make sure that that doesn't feel like a critique of you? And I just want to call out one quote to illustrate this. As I was doing my PhD work recently, you publish things, people will challenge you. And I had people challenging some of the things I had written. And one of my supervisors, Dr. Lara Varpio, who's one of the most insightful people I've ever encountered, said, someday someone will make an entire career out of tearing yours down. There's nothing that can be done about it. And that is how science progresses. And it's so true. And how do we make sure that we maintain curiosity and humility to move the field forward without feeling tied to the presentations we've given or the papers we've written, because we know things will change?
Great question, Ben, and I love the quote from Laura. I think my journey has really helped to illustrate how I would answer that. I have to be a little careful and I check myself from time to time where I was at the forefront of helping to introduce competency-based training in the US and particularly in internal medicine. And then now if I come, I don't know, 15, 20 years later, a lot of people might actually suggest that I'm a CBE skeptic. I'm a CBE skeptic. And I don't think that I am, but I do want to check us about how it's evolved. And I kind of, when I'm in the room, I kind of serve as the person that says that's great and that's wonderful. But how's the rest of the world going to do that? How is every low-resourced institution, because as in our context, it's not just the academic medical centers. We have family medicine residency programs that have 10 residents in the entire residency program and are located in a community hospital that has 150 beds. How is that institution going to be able to achieve this? So I want to try to, I keep trying to walk that back and kind of tear down even the stuff that I built before. I wanted to show specifically that slide about then a miracle occurs because I've changed how I use that. And I think until we began thinking about this particular webinar series about the narrative and the story, I didn't really consider it as being the narrative piece. And the last part is who's really influenced me and my thoughts about actually being humble enough to tear down some of the stuff that I had to help to establish was the work we've done. Some of us have done, I guess you and Adele and I have done with our colleagues in low to middle income countries, and the really profound influence they have had on me in thinking about how we can accomplish CBE moving forward. You're unmute them.
It's only 2026. I'm doing great. I was just saying thank you for those reflections. Really appreciate it. And I think this is something we're all going to navigate both locally and nationally for people who are putting themselves out there to try to innovate and do new things. And then they write about it, especially because you're kind of frozen in the words that you put out into the world. So thank you so much. I know we're coming up on the last few minutes. Before I wrap, does anybody have any other questions that they want to put in the chat for Dr. Atkinson or Dr. Kavarzegi? Just some thank yous, amazing reflections. I'm not seeing any right now. Well, if I can wrap, I will just say a huge thank you, Adele, Kelly. Thank you for sharing those stories with us. Again, I think there is something more vulnerable feeling about sharing a story rather than just sharing didactics and data, even though stories woven throughout all of it. And I really appreciate you both being vulnerable and willing to share those. It really, both of them, like I could feel them in my chest in a way that I wouldn't some other didactics. So I think you hit the mark. And I want to say thank you to everybody who tuned in for us. I'm going to put my email in the chat. Please feel free to send any feedback you have on this format to us. We're going to be doing more stories throughout the spring. We have some other great storytellers lined up who are going to take the baton and tell different types of stories around competency-based education. If you have a great story and are a good storyteller, or you know of a great story and storyteller, please reach out to us. And we especially would love stories from a diversity of contexts, humans, specialties, fields. We want to really hear stories from all over the place. So please, please, please feel free to reach out to us, pass this along. And we hope this was helpful for you and that this kind of spurred something in you. Thank you again for joining us, and we'll see you at the next ICBHPE webinar. Thanks, everybody.